Uh, I hope that you can see my screen.
Yes.
Perfect.
Good. Perfect. So, so thank you very, very much for this kind introduction. And once again, thank you very much for inviting me. And I would like to discuss with you today the rehabilitation in osteoporosis, and more particularly, the effect of rehabilitation after fragility fracture. You are obviously aware of the major burden of osteoporosis. You are obviously aware that fragility fractures are associated with major health outcomes, with a reduced health-related quality of life, with an increased risk of subsequent fractures. So that's a major public health burden. The good news is that we've got some effective treatment to manage a patient with a fracture, and that pharmaceutical agents are proposed to our patient, and it's a very good point, because it could reduce the number of new fractures. However, there are still some pain, there are still some limitation in physical function because of fracture. That's why we still need to manage patients with osteoporosis and with fracture with non-pharmacological therapies. Moreover, we also know that there are other risk factors for future fracture, such as sarcopenia, frailty, a poor diet, low muscle strength or power, poor body balance, and so on. So we need to manage it once again with non-pharmacological agents. And it has been suggested by different international societies that the greatest outcomes after a fragility fractures are obtained when we use a patient-centered multidisciplinary care. That's why I would like to discuss with you today some global rehabilitation, including the exercise principle and the different characteristics of these exercises. We will also briefly discuss fall prevention programs, but also physiotherapy, nutritional care, patient education, and at last we will discuss the care pathways. So let's start with the exercise principle and the characteristics. As a matter of fact, many scientific societies, and it's, for example, the International Osteoporosis Foundation, describe exercises program for the treatment of the prevention of osteoporosis and its complication. And basically, if we look at all different scientific recommendations, they propose as exercises progressive resistance training, weight-bearing exercises, and also exercises with a focus on body balance. And if we look at what's generally recommended, it's progressive resistance training 2 times a week, weight-bearing impact training 4 to 7 times per week, and functional body balance, agility, coordination training 30 minutes 4 times a week. So as you can see, I would say that all exercises therapy is quite effective, but must be performed on a very regular basis. And if you would like to have some idea to propose to your patient to perform some progressive resistance training, weight-bearing impact training, or exercises with a focus on body balance, there are some web tools such as the To Fit the Fracture recommendation with some exercises that you can share with your patient. Of course, in other websites, such as the website of the International Osteoporosis Foundation or the website of Osteoporosis in Canada, there are many very useful exercises proposed by this society, once again, that you could share with your own patient. However, I think that it's fair for me to acknowledge that all this evidence supporting the recommendation of resistance training, body balance exercises has been developed in a pre-fragility fracture population. So it's clear that we've got some high level of evidence suggesting that all these exercises are very useful in the prevention of the first fracture. However, we should acknowledge that we have less data suggesting that all these recommendations are really effective in patients with a fragility fracture. However, we've got some evidence. And for example, if we look at systematic reviews and meta-analysis, and for example, here in this systematic review and meta-analysis performed and proposed by the Cochrane collaboration, they say very clearly that exercises could have some benefits to improve the pain of the patient, to improve the physical function, and to improve the quality of life of the patient with a vertebral fracture. However, the findings are quite inconsistent and the quality of the evidence was very low. It means that we do not have a large, well-designed, randomized controlled trial confirming that exercises is really effective in patients with a vertebral fracture. However, once again, from what we know in patients without vertebral fracture, and even with the low quality data that we have in patients with vertebral fracture, I think that it's fair, once again, from the scientific societies to propose exercises in the management of a patient with vertebral fracture. What's very interesting for our patient is that it's always better for sure to have exercise therapy performed in a hospital or performed in the unit of a physical therapist, in the setting of a physical therapist. However, it's very interesting to observe that even home exercises is very interesting for the patient, and that it's sufficient to have a physical therapist going to the home of the patient to propose a few exercises during the first few weeks after the vertebral fracture. And then if we look at the compliance to exercises, it's quite good for half a year. But then we need to have the physical therapist back to the home of the patient in order to motivate once again the patient in order to give different exercises. And we can see that we still have a good compliance to the patient, at least for 8 months after the vertebral fracture. So it's important to have in mind that also exercises performed at home is effective to reduce the pain and improve the quality of life of our patient. However, we should acknowledge that we should pay attention with a patient with a vertebral fracture, because you are obviously aware that a new vertebral fracture is a major risk factor for a new fracture. So we need to be quite cautious with the exercises proposed to the patient. And so we suggest, and scientific societies suggest, that activities that involve rapid, repetitive, weighted, or end-range twisting or flexion of the spine should be avoided. So once again, in patients with a very recent fracture, we need to pay attention in order for not to have a new fracture just because of the exercises. However, if we give the exercise, or if some highly specialized therapist, such as a physical therapist, a rehabilitation specialist, and an MD with some expertise in exercises, give some recommendation and give the exercise to the patient, then it is suggested that the impact of exercises outweighs the risk of further injuries. If we look now at hip fracture, we've got more evidence. And for example, we've got this meta-analysis of randomized controlled studies suggesting that progressive resistant exercises could have a significant benefit on physical function after hip fracture surgery. So once again, progressive resistance training is effective. Interestingly, it has been also suggested, once again coming from a meta-analysis of randomized controlled trial, that body balance training could improve the activities of daily living after a hip fracture, suggesting that, once again, body balance should be part of the exercises recommended for your patient after a hip fracture. If we look also at another meta-analysis, it was suggested that structured exercise could produce an improvement on the overall mobility after the hip fracture. But once again, it's mainly in interventions that included progressive resistance training that we've got the more beneficial effect. So once again, all exercises are effective, but if you perform some progressive resistance training and body balance exercises, you improve much more the mobility of your patient. If we look now at fall prevention programs, it's quite interesting to have a look at the recent recommendation of the Cochrane collaboration. And the Cochrane collaboration suggests once again that exercise programs could reduce the rate of falls. However, we should acknowledge that we do not have many scientific evidence that exercise programs could also reduce other non-falls outcomes. So it's not clear if we are able to reduce the fracture of the patient, if we are able to reduce the hospitalization of the patient, or if we are able to reduce the nursing home admission. So once again, if our objective is really to reduce the fall of the patient, let's be clear, exercise programs could reduce the rates of falls. interestingly, if we want to have a major effect, we need to have exercises that involve body balance and functional exercises. And it has been suggested that Tai Chi, because of the high impact on the body balance, could also have an effect on falls. Let's be clear, we have less evidence here for the effect of progressive resistance training. So, let's be clear. Resistance training is very effective to improve the quality of life of a patient with a fracture or without a fracture. But if your main objective is really to have an effect on the fall of the patient, then you need to have exercises with an involvement of the body balance and the functional exercises. It has also been suggested that multifactorial intervention could reduce the rate of falls. So multifactorial, by definition, we have an effect, or we try to have an impact or to target different factors associated with the risk of falls. And it's mainly the effect on muscle strength, on body balance, the effect of also on the nutrition and the poor nutrition of the patient. So let's be clear, here if we focus on different factors, we are also able to reduce the falls of the patient. And once again, we need to include exercises. So it's good to have a focus on different factors of falls. However, we still need to have the exercises therapy. So whatever you propose to your patient, a good nutrition, the education, pharmacological intervention, it's good. However, you also need to propose exercises to your patient. Let's move now to physiotherapy in patients with a fracture. As you know, physiotherapists, it's different strategies, including functional mobilization, transfer training, safety training, patient education, postural taping, manual therapy, and the use of assistive devices, with the addition, of course, of exercises. So once again, a strong focus on exercises, but with the addition of different non-pharmacological modalities. It's very interesting to observe that, if we decide to have a high intensity physiotherapy compared to a control group. So high physiotherapy intervention and a control group with a moderate physiotherapy. So high physiotherapy compared to moderate physiotherapy, we can see that the probability of discharge in the high physiotherapy intervention is greater than in the control group. So the patient go back to home much more quickly, suggesting that high intensity physiotherapy is highly effective, probably to improve the mobility of the patient, to decrease the pain of the patient, to improve the mobility, to improve the physical function of the patient. It was also suggested that if we have, just after the fracture. So once the patient come in the hospital, immediately we've got a physiotherapy compared to a delayed physiotherapy intervention. So only a physiotherapy after a few days after being at the hospital. It was shown that the mortality was significantly higher in the delayed physiotherapy intervention compared to the immediate physiotherapy intervention, suggesting once again that it's very important to start the intervention with, of course, exercises, but also other non-pharmacological treatment modalities as soon as possible after the fracture. However, we should acknowledge that we do not have a lot of evidence regarding all tools that could be used by the physiotherapist. And for example, orthotic devices or taping has not been shown to be effective in all clinical trials. So once again, it's interesting to have a physiotherapist intervention, but pay attention to what's proposed by the physiotherapist. It's also very interesting to observe that, as discussed before, physiotherapy performed at the home of the patient is better than no physiotherapist and is similar to an outpatient physiotherapy. So once again, suggesting that if the patient is not able to go to the hospital, is not able to go to the office of the physiotherapist, it's still possible to have some whole physiotherapy, and that's effective. We are able to improve the pain of the patient after a hip fracture. It's also quite interesting to note that it was suggested that motivational interviewing increases physical activity and self-efficacy in people living after a hip fracture. And it was a randomized controlled trial. And if I put here in the physiotherapy intervention, it's that I of course that I'm fully aware that motivational interviewing could be performed by many specialists in the field of bone. However, I also strongly believe that it's mainly the physical therapists that have more time to spend to perform this motivational interviewing in order to perform this kind of education of the patient, once again, because they see the patient much more regularly, and at least in Belgium, where I come from, at least during 30 minutes, probably 2 or 3 times a week. So they have the possibility to perform and to educate the patient. Very quickly, I just would like to highlight the importance of nutritional care. Why? It's because it was shown that in patients after a hip fracture, if we start to promote, if we try to assess the risk factor of the future mortality after a hip fracture, it's very interesting to observe that malnutrition is an important risk factor for mortality after fracture, suggesting that we need to take care of this malnutrition. However, we should acknowledge that we do not have many randomized controlled trials suggesting that or confirming that nutritional care is able to really improve the outcome after a fracture. However, we have some data suggesting that if we give nutritional supplementation just after a hip surgery, we are able to reduce some complications of the surgery. It was confirmed in another systematic review performed by the Cochrane group. So once again, we are able to reduce the complication of the surgery if we give some nutritional supplementation to our patient just after the fracture, but it's less clear if we are able to have an important effect on morbidity, mortality, quality of life, and so on. So we are able to reduce the complication of the surgery. We have less data related to other health outcomes with the nutritional supplementation. Let's move now to the patient education once again after a fracture. And if we look at recent systematic review, we can see that if we look at all or the main randomized controlled trials having assessed the effect of education, it was able, all these trials have been shown that they are able to improve the education of the patient and to improve the knowledge of osteoporosis, to improve the medication and the knowledge on the medication, and the patient also is much more aware of the importance of diet and exercises. It was also shown that group education, so education performed in a group, so not individually, but in a group, could also increase the patient knowledge of osteoporosis, the health-related quality of life of the patient, the physical activity in patient after a fracture, but also the psychosocial functioning. Interestingly, if we ask patients after a fracture or with osteoporosis what they would like to be informed, so what should be the content of an education program? So of course, it's the nature of osteoporosis, the importance of the fracture risk and the risk factor of future fracture. Of course, it's related to the importance of the medication and also the self-management of osteoporosis. However, it's very important also, apparently, because it was an information from the patient. They would like to be informed on the role of dual X-ray absorptiometry and the role of these tools in the follow-up of the patient. So if you would like to perform some education of the patient, so of course you need to educate the patient on the importance of nutrition, the importance of calcium, vitamin D, the importance of exercises, the importance of physiotherapy, the importance of many things, but also on the importance of other tools to manage and to monitor the patient. At last, I would like to finish my talk with some discussion on the care pathways, because you are, I presume that because you are interested in bone diseases, you are interested in osteoporosis, you are obviously aware that if you have a low bone mass, you are at an increased risk of osteoporosis and fracture. You are obviously aware that if you have a fracture, you have an important risk of future fracture. However, many practitioners, and by the way, most of the patients are not aware of that. So it means that if, and I see that every day in our hospital, it means that we've got some patient with a fracture, they come back home without pharmacological or non-pharmacological management of osteoporosis or fracture. So we need to do something. We need to do something. We need to explain other medical doctors that, hey, this patient has a fracture, it has to be managed. You cannot send the patient back home and without any treatment, pharmacological or non-pharmacological. That's why different models have been developed, including what we call orthogeriatric units, or more recently, the fracture liaison services. Let's be clear, it's quite new, but in different hospitals where it has been tested, it has been shown that patients are much more quickly managed. They receive much more pharmacological and non-pharmacological treatment, and at the end of the day, they have a better quality of life. So it's important to try to build a fracture liaison service in different hospitals. But let's be clear, it's very complex. I'm not a specialist of the fracture liaison service. There are other specialists at the International Osteoporosis Foundation, but I know that it's something very important in order to manage a patient after a hip or a vertebral fracture. If you are interested by the fracture liaison service, you can have a look at the Capture the Fracture website organized by the International Osteoporosis Foundation. And so my conclusion is what I put in the introduction is that I'm strongly in favor of multidisciplinary care of patients after a fracture. And of course, I'm fully aware of the importance of pharmacological intervention, because we are able to reduce the new vertebral or non-vertebral fracture by 50%. However, we also need to have non-pharmacological treatment modalities, because they have been shown to improve the quality of life of the patient, to improve the functional outcome of the patient, to also to reduce the mortality. And so once again, among all these non-pharmacological intervention, I think that you need to include a lot of things: nutrition, education, physiotherapy, fall prevention program, and so on. However, I think that you need to include exercise therapy. I think it's very important to keep in mind that it's very important in the prevention, in the primary prevention of the fracture, but also as the secondary or tertiary prevention of a fracture. So once again, keep in mind that exercises is probably the best treatment in the world. So I just would like to thank you very much for all your attention, and I would be more than pleased to try to answer all your questions. Thank you once again for your attention.
Muchas gracias, profesor Bruyère, por la excelente presentación. Ahora vamos a dar inicio a la sesión de preguntas moderada por la doctora Tania Szejnfeld. Pueden enviar las preguntas en el icono que dice preguntas y respuestas, y también por el chat veo, Tania, que hay algunas preguntas para comenzar.
Well, congratulations, Dr. Olivier, for your brilliant presentation. And I would like to congratulate you on all your papers among the subject. I've read some of them yesterday, and they are so complete towards physical and diet and sarcopenia and frailty and osteoporosis itself. So thank you for summarizing it in this brilliant presentation. I took shots of almost all your slides so I can study later. We have 2 questions at the chat, but I would like just to start with one question. So you said in the beginning of your presentation about all the studies in physical functioning in pre-frailty subjects. So my tough question here is whether when we have a frailty scenario already installed, so whether we have a wheelchair patient or someone with a disabling capacity, what kind of strategy would you suggest in order for us to reduce impact of a hip fracture or either a vertebral fracture?
Thank you very much for your kind word and this question. That's a quite complex question. Let's be clear. I would say that unfortunately we do not have many scientific papers dealing with patients with high disabilities or with very old patients. And let's be clear, I think that's it's a problem, and that's what we call the ageism. It's a pity because we treat many very older patients, but we do not have many scientific papers on this particular population. That being said, I think that from all scientific papers that I have read on this particular topic, it's quite clear that if we perform some exercises, it's still beneficial for the patient, at least to improve the mobility of the patient. There are also data suggesting that if we are able to improve the mobility of the patient, if we are able to give some exercise to the patient, it will also impact the nutrition of the patient because the patient will eat much more easier compared to if the patient has no physical activity. So once again, I'm really in favor of physical activity, even in patients with high disability.
Well, thank you very much for answering that. It was a tough one. I have a couple of questions of our audience, and I would like to highlight that in our audience today, we have some Brazilian doctors that friends of mine, like Dr. Perola, Dr. Fabio, Dr. Fania, and they study a lot that topic. So hope they are having good time now. So Roberto Coronado from Mexico has a question for you. Like, do you have suggestions for
Hello, I think.
how are you willing to classify the diagnosis of sarcopenia? Which tests would you analyze and assess muscle mass quality and quantity, do you suggest DEXA or have you considered ultrasound? What cutoff points do you suggest? Do you have any treatment suggestions in patients with the osteoporosis with very high risk of fracture with sarcopenia? Well, he has like, maybe you can summarize, but I think we understood he has questions about sarcopenia, right?
Yeah, but let's be clear, sarcopenia is a major risk factor of future osteoporosis. So there are some longitudinal data suggesting that if we have a patient with sarcopenia, they will have more fracture and they will have more osteoporosis. They will lose more bone compared to a patient without sarcopenia. Now, regarding I would say the diagnosis of sarcopenia, but let's be clear, currently it's recommended to use a dual X-ray absorptiometry. I think it makes sense, especially for us, because we are also interested in bone. And so with the dual X-ray absorptiometry, we are able to diagnose osteoporosis and also sarcopenia. However, I also know that it's not always easy to get access to dual X-ray absorptiometry. I don't know how it's happened in Latin America, but even in Belgium, in some hospitals, it's quite complex to have access for that, just for the diagnosis of sarcopenia. So sometimes we cannot always recommend it. So sometimes we could also use BIA, bioimpedance analyzers that could be used just to have the information on the sarcopenia of the patient, or at least the lean mass of the patient. And then what should I do with a patient with sarcopenia? Let's be clear. I would say that it's very simple, because currently we do not have a pharmacological treatment. To the opposite of what we have in osteoporosis, we have very effective treatment for osteoporosis. Currently, for sarcopenia, we do not have a magic pill that will build bone. So I would say that, once again, what should I do? It's progressive resistance training. And I think that it's the only evidence that we have that we could reduce the burden of sarcopenia. It's with resistance progressive training. And I would say that I think that for us, once again, it's even more interesting, because progressive resistance training could have an impact on bone and could have an impact on the muscles. So it's a win-win situation.
I totally agree with what you just said, and I tell the same to my patients. So I would like your comments on two questions. Whether there's a patient that cannot be in orthostase, whether like arms and ABS are enough dealing with all this context. And second of all, in Brazil, we have like two colleagues asking about the Vibratory platform for patients that cannot do resistance training. What are your comments on that?
I will start with this one, because I had the privilege almost 20 years ago to design one of the very first trial by the way, it was the first trial on whole body vibration in a nursing home setting. So we put this kind of apparatus in various nursing homes, and we were able to show that we were able to have an impact on different tests, such as the get up and go test, such as the TINETI test. So we had an improvement in the motor capacity, in the physical function, in the body balance. So, and there are more recent researches suggesting that whole body vibration could also have an impact on bone mineral density. So I'm quite in favor of this kind of treatment, especially in patients that cannot or do not want to perform some physical resistance training. Regarding the first question, I answer it indirectly, but one of my favorite clinical trial was a clinical trial comparing, it was 3, but let's say 2 different treatment, non-pharmacological treatment modalities. One with very high resistance training, and the other one with very, very low resistance training. So of course, the first one was the very high resistance training, but with a very low number of repetitions, and the low resistance training with a very high number. So it was 100 repetitions, so almost with no resistance. So something's very difficult, something very easy. As we could expect, the highest improvement in muscle strength, muscle endurance, physical function was observed with patients with the high resistance training, suggesting that we need to recommend high resistance training. However, even in the low resistance training, there was some improvement, and quite high improvement, of muscle strength, muscle power, muscle resistance, and so on. So, of course, that we have the highest effect in the high resistance, but we still have an important effect in the low resistance. And so what I say to my patients is that, okay, you do not want to perform high resistance training, do something else. The most important is that you perform something. It's always good for you. Of course, if you have to choose, if you would like to do anything, do the high resistance training. It's better. But if you do not want to do that, if your patient do not want to do that, okay, let's do something else. It's still good for the patient. I think that we need to have that in mind.
I think I saw this paper and it's brilliant. And maybe my thoughts about it, it's about endocrine power of exercise. I mean, IGF-1 and everything, that it starts just by moving your muscles. Even though you're not gaining strength or power, you're moving, and this is good for the body.
Yeah, and I agree with you, and if I refer to the study that you are referring to, it was also shown that just simple exercise could reduce the chronic inflammation, and that's why it could also be good for the whole body, not only for the muscles or the bone, but for the general health of the patient. I fully agree with you.
And using those thoughts, I would like your comments on protein supplementation. Would you then do that right after the exercise and gain your improvement in muscle mass? Or regarding the patients that you have, this is, I mean, you don't recommend, or you don't see fit to recommend a special time of the day to supplement?
Let's be clear, I'm not a specialist of the nutrition, but from what we can see in the scientific literature, it's quite important to have, I would say, a patient-centered approach. It means that probably that all patients with a fracture or with a hip fracture should not receive a nutritional supplementation. But if you have a patient with a low nutritional status, with some kind of malnutrition or at risk of malnutrition, we could propose some nutritional supplementation. And maybe that a nutritionist, a specialist in the nutrition should say that, hey, for this particular patient, maybe that we need this particular supplementation or another supplementation. From what we can see in the scientific literature, if we give supplementation to all patients, it's not effective. But if we give some supplementation in patients that really need the supplementation, we have some significant effect. We've got also some data suggesting that we could also have an additional effect of the nutritional supplementation with the exercise therapy. So an effect of the exercise, an effect of nutrition, but if we give both, we have an additional effect. So probably that for some patients, both treatment could be recommended.
About that supplementation and malnutrition, which are the laboratory markers that you use to study whether a patient is under malnutrition or not? Do you use albumin? How do you analyze that?
Currently in our lab, in our department, it's mainly albumin. However, there are now some more recent recommendation regarding the diagnosis of malnutrition using what we call the GLIM criteria, and other factors or the biological marker could also be assessed in order to have a full definition of malnutrition. On the other side, probably that sometimes with some, I would say, easy to use screening questionnaires, we could also already have a view on the status of the malnutrition of the patient, and maybe that in most of the clinical practice, it could be enough.
Okay, now going through supplementation and diet things, which interest a lot of us and the colleagues that are online now, I have two questions for you about vitamin D supplementation in patients like in old patients and very old patients. Whether do you need to go further, which is your number? And the second about protein enhancers or boosters, supplements such as HMB or leucines or amino acids. Which one do you prefer most, and how do you use it for those patients?
Let's start with vitamin D. Currently, we've got some data from the most recent meta-analysis suggesting that vitamin D with the addition of a calcium supplementation could reduce falls of the patient and could also reduce the fracture of the patient. However, we've got also some data suggesting that it's much more effective in patients with a low level of vitamin D at baseline. It's the same story as the protein and the nutrition. If you give some vitamin D in patient with a already high level with sufficient level of vitamin D, it's probably useless. So it's probably interesting to have the status of the vitamin D of the patient. However, on the other side, to assess the vitamin D of the patient, it's costly, and maybe that it's not so easy to do this to do that so regularly in the clinical practice. So maybe that in the very old patient, some vitamin D supplementation for everybody could be an option. And regarding the dose of vitamin D, I would say quite simple with the I would say the normal range. I would say 80, 100 to 1,000 international unit per day. You could also give that once a week or once a month, 25,000 international unit per month. It's also something possible. Maybe that in patient with very low level of vitamin D, maybe that you can start with a more important vitamin D dose. But in most of our patients, I would say that the optimal dose of vitamin D should be, I would say, 1,000 per day. Regarding your second question on the different kind of proteins and different leucine or something else, my position is that I would take some supplementation that has been shown to have an effect in the clinical trials. So I would favor a product that has shown to have an effect in a clinical trial. So because we know that if I go to my supermarket, I can have thousands of supplementation. I would favor supplementation that has shown an effect in a clinical trial, and then I would have a look at the clinical trial in order to see if it's related to my own patient. If it's not related to my patient, to my kind of patient, I will not use that kind of product. So I'm sorry not to be able to answer really the question of what kind of protein should I take. It's once again, I would favor a product that has shown to have an effect, a real effect in a clinical trial.
But I do think you and that their use must be used cautiously or as recommended. I mean, they are not something like magical portion for sarcopenia or falls or osteoporosis or anything like that. And they do not, they are supplements and they do not do all the efforts among building muscles or strength or anything. So I do agree with you. And maybe I will put two questions of the audience here together since they match a little bit. So Fabio Tavano, which is an orthopedic surgeon of the shoulder. I do know him, he's from Brazil. And he would like to know more about rehabilitation in upper extremities. And there's just another participant that wants to know about whether it's the best timing to start rehabilitation towards vertebral fractures. So you didn't go a lot for the orthosis. So how do we deal whenever patient doesn't have to walk? What are your recommendations? Is pain?
Yes, sorry, I had some internet connection problem, but I think that I've got part of the question regarding the rehabilitation of the upper extremities. I think it's very important, and from what I know from the scientific literature, the most important there is to have an optimal mobility. Having some physiotherapy dealing with the reduction of the pain of the patient and the improvement in the mobility of the patient is probably the most important. Having a strong muscle at the upper level, it's less interesting because it will not prevent of the fall, it will not prevent really of the fracture. So probably that for the upper extremities, the most important is to reach an optimal level of mobility, just in order to have the possibility to have normal activities of the daily living. Regarding vertebral fracture, I would say that orthosis could be interesting in some of the patient, but once again, I think that you need to choose the optimal patient that should receive an orthosis. It could be useful for some patient, and probably that the optimal management is really to start with the reduction of the pain of the patient. Maybe that the physiotherapist could help with that, and then to educate the patient and to try to improve the mobility of the patient. On the other side, I think that it's very important, even if we cannot move the spine because of the fracture, it's important to keep some kind of mobility at the lower limb and to keep an optimal muscle strength. So I think it's important, if the patient is able to do that, to keep some kind of flexibility on the joint, but also to try to, I would say, to stop losing muscle mass or muscle strength, because we know that if a patient is not able to move because of the vertebral fracture, and if they stay in a chair or in the bed, they will lose mobility, they will lose muscle mass, muscle strength. So I think it's very important to try to keep the flexibility and to increase the muscle strength of the patient, or at least to reduce the muscle loss of our patient.
I couldn't agree more. And it's so important for us to know the whole patient. So I will ask Victoria if I can have one more question, or whether we have to...
No, yes, sure, Tania. Go ahead. We can have one more question. I think that, Tania, you're having a little bit of connection problems, right?
Connection? Yes. Not good
yes,
now?
I can hear you now. I can hear you now. Yes, we can have one more question.
So our final question, which is, I think it's the most difficult one now. How do you educate your colleagues about, like, showing the patients that they have fragility fractures, whether they don't want to treat or they do want? How do you educate your colleagues?
You know that probably that my first my first meet the expert session, so that I gave 10 years ago in the World Congress on Osteoporosis, was attended by, I would say, 25 scientists, and from them, only a few of them were medical doctors. Last year, I gave some meet the expert session on the rehabilitation in osteoporosis, and it was attended by much more medical doctors. So I think that they are much more interested now for to have a better knowledge of the rehabilitation in osteoporosis. So to answer your question, I think that one very interesting place where I could educate the patient is in our hospital when we designed the fracture liaison service, because we had some regular meeting with different specialists in the field of the different part of the management or the care pathways of the patient. And so it's probably during that meeting that I could educate some of my colleagues. So I just would like to stress the importance of the fracture liaison service. And if I can finish with that, I think that when I see the number of attendees in this particular session, it means that clearly it's a topic of primary importance. And I'm not sure that 10 years ago we would had some so high success of this kind of session.
In addition to that, what you said, yes, there is increasing interest among this topic and in your work. I mean, you have a lot of knowledge and experience, so we are very honored to talk to you today and to learn from you. And for sure, you have enriched a lot our clinical practice. And also, I'd like to say that just last week, we lost a good friend of ours. His name was Bernardo Stolnicki. He's an orthopedic surgeon that was one of the masters of FLS in Brazil. So we are now kind of trying to be better and keep up with all his work and all he done in Brazil and with us.